All right, everybody. This is question one of the 100 days clinically oriented anatomy questions. So let's get straight into it. It says a 42-year-old man is admitted to the emergency department after his automobile hit a tree and is treated for a pelvic fracture and severe deep lacerations. Physical examination reveals that dorsiflexion and inversion of the left foot and extension of the big toe are very weak. Sensation from the dorsum of the foot, skin of the sole, and the lateral aspect of the foot has been lost, and the patellar reflex is normal. The foot is everted and plantarflexed. Which of the following structures is most likely injured? Option A, lumbosacral trunk and linea terminalis. Option B, L5 and S1 spinal nerves torn at the intervertebral foramen. Fibular division of the sciatic nerve at the neck of the fibula. Sciatic nerve injury at the doorway to the gluteal region, tibial nerve in the popliteal fossa. So I've marked out the important details about the question. We're not interested in all this extra information. The things that concern us here are what I've underlined, and they are. He said, does the flexion and inversion of the left foot, extension of the big toe are very weak? So the first part of the question told us about myotomes basically, and then here we have sensations from the dorsum of the foot, skin of the sole, and the lateral aspect of the foot has been lost. So those are dermatomes. The question went further and told us the patellar reflex is normal, the foot is everted and plantarflexed. So it means eversion and plantarflexion of the foot is still normal also. So which of the following structures is the most likely injured? So let's start from option E. Tibial nerve in the popliteal fossa. Tibial nerve supplies the posterior compartment of the leg, and the posterior compartment of the leg is responsible for plantar flexion. So we have the muscles that are present in the posterior compartment of the leg are the gastrocnemius, both the medial and the lateral heads, the plantaris, the soleus muscle, the tibialis posterior, and the flexor muscles, the flexor digitorum longus and the flexor hallucis longus. So those are the muscles that are responsible for plantar flexion. And the question told us that the patient can plantarflex. So it means those muscles are still intact, which means the tibial nerve in the popliteal fossa is not affected. So option E is out of the options that we are considering. Option D says sciatic nerve injury at the doorway to the gluteal region. If the sciatic nerve is injured at the gluteal region, all the muscles supplied by the sciatic nerve will be affected, and all the posterior leg muscles, that is the hamstring muscles, all the muscles of the leg, both the posterior compartments, the anterior compartments, the lateral compartments, all of them will be affected. So that is not the case here. So which means option D is not the correct answer. Option C, fibular peroneal division of the sciatic nerve at the neck of the fibula. First thing is that the fibula did not bifurcate from the sciatic nerve at the neck of the fibula. The sciatic nerve bifurcates into the fibula, the common peroneal nerve or the common fibular nerve, and the tibial nerve at the junction of the upper two-third and the lower one-third of the posterior thigh. Alright, that is where it divides into the common peroneal nerve and the tibial nerve, and that is not what they mentioned here. So what happens at the neck of the fibula is the bifurcation of the common peroneal nerve into the deep fibular nerve and the superficial fibular nerve, and that is not the case. That does not have to do with what we are discussing here. So we have option A and option B left. The lumbosacral trunk and linea terminalis and the L5 and S1 spinal nerves are the intervertebral foramen. So the lumbosacral trunk and linea terminalis, the lumbosacral trunk basically is formed by nerve roots from L4 and L5. That is what forms the lumbosacral trunk. So which makes option A L4 L5, then option B L5 S1. So we are basically considering those two options. Let's go back into the question now. Remember I mentioned the first part of the question told us about myotomes. That is the nerve roots that are responsible for different actions at different joints. And then the later part of the question discussed dermatomes, that is cutaneous innervations of nerves. Let's check the first part of the question. Does the flexion, inversion, and extension of the big toe are very weak? So here I've added important myotomes that we'll use to solve the question. Flexion of the hip is controlled by L2, L3. Extension of the knee is controlled by L3, L4. Dorsiflexion is controlled by L4, L5. Extension of the hip is controlled by L4, L5. Flexion of the knee is controlled by L5, S1. Plantarflexion is controlled by S1, S2. Inversion of the foot at the ankle joint is controlled by L4, L5, and inversion is controlled by L5 and S1. So a simple trick to understanding these myotomes is that all the actions that are happening or that are taking place at the anterior portion of the body follow a particular sequence from L2 to L4. That's from L2 to L5 rather, sorry. While all the actions at joints that are occurring at the posterior portion of the body extend from L4 to S2. Now what do I mean by this? Flexion of the hip. Flexion of the hip is at the anterior part of the body. The myotome for that is L2, L3. Extension of the knee. Extension of the knee is towards the anterior portion of the body also. That is L3, L4. Dorsiflexion is still towards the anterior portion of the body, which makes it L4, L5. So it follows the sequence L2, L3, L3, L4, L4, L5. And then to add extension of the toes is also L5, S1. So it is still a continuation of the sequence we've been following. So to the posterior movements, so all the actions occurring at the posterior region of the body follows the sequence from L4 to S2. Extension of the hip is towards the posterior portion of the body, L4, L5, controlled by L4, L5. Flexion of the knee is towards the posterior portion of the body, L5, S1. Plantarflexion is towards the posterior portion of the body, S1, S2. Also, flexion of the toes is S2, S3. Still the continuation towards movements along the posterior side of the body. So the other ones are inversion and eversion at the subtalar joint. Inversion is controlled by L4, L5 myotome, while eversion is controlled by L5, S1 myotome. So yeah, let's now go back to our question. Dorsiflexion, inversion, they are weak. What are the myotomes of dorsiflexion and inversion? Dorsiflexion is L4, L5. Inversion is also L4, L5. Don't forget the lumbosacral trunk is formed by L4 and L5. So which means that this movement will actually be affected if the lumbosacral trunk is injured. So from here, our answer is option A. Let us check the other aspect of the question. Sensation from the dorsum of the foot, skin of the sole, and the lateral aspect of the foot has also been lost. Now, the cutaneous innervation of the dorsum of the foot and the skin of the sole is L5, yes. While the dermatome to the lateral aspect of the foot is actually S1. Yes, it's S1. So dorsum of the foot and skin of the sole, the cutaneous innervation is L5. While lateral aspect of the foot, you have the sural nerve, which is S1, although it takes a branch from L5, S1 actually. So yeah, they mentioned the patellar reflex is normal. Now you could wonder why the patellar reflex is still normal, even though the patellar reflex is controlled by the L2, L3, and L4 nerves, predominantly by the L4. Yes, it is predominantly by the L4. The L4 spinal nerve predominantly controls the patellar reflex. All right. Now, why is the patellar reflex normal? It is because the lumbosacral trunk is the one injured and not the L4 that controls the patellar reflex. The L4 that controls the patellar reflex is from the femoral nerve, right? It's from the femoral nerve. So it is a branch of the femoral nerve that forms the L4 that controls the patellar reflex. So I believe that is clear. So if the lumbosacral trunk is injured, even though the lumbosacral trunk is L4 and L5, the patellar reflex could still be normal. Yes, that is very possible. It will still be normal because, like I mentioned, the L4 controlling the patellar reflex is from the femoral nerve and not really from the lumbosacral trunk. So the question mentioned that eversion and plantarflexion is still normal, which makes the tibial nerve not our correct answer. Since plantarflexion is still normal, it means the posterior compartment of the leg is not affected. So from the foregoing, L5 and S1 spinal nerve is not our correct answer. I mean, it's not the best answer to go for in this case, since the majority of the things that are affected in this patient's body is actually controlled by the L4 and L5, which forms the lumbosacral trunk. So this is the correct answer. This is the correct answer. The lumbosacral trunk has linear terminalis. So I want to believe you understand why the lumbosacral trunk is correct and why the other options are wrong. So tune in for more episodes. We are going to 100 questions. So this is question 1 out of 100. I hope you enjoyed and you gained from this video. See you in the next video. Bye.